Here in a second. We are sort of back at our 2021-22 spine curriculum. Up on the screen right now is our sort of initial run at topics that we're going to cover this year. This will take us from November through June. And really, we think covers the primary topics that spine fellows and residents need to see. Some of these topics for some of the residents might sound familiar because we go through them year by year. We've tweaked the talks, tweaked the speakers a bit, and want to make sure everything's actually fresh and up to date. But this really should be good prep for the fellows, good prep for boards, and then good baseline information for sort of junior residents. We do have two journal clubs, one at the end of February, one in June. Our fellow will sort of oversee and manage the article selection with me, and then we'll get articles out to everyone well in advance. But this is right now our primary kind of our initial run at lectures. To take a look, screenshot it. Otherwise, we'll make sure we email it out to everyone as well. And then I will share my PowerPoint in just a second here. If folks feel comfortable with it and are open to it, it'd be great to have cameras on, only because that, from past experience, makes the discussion that much better. Two shakes here. Nope, wrong talk. Sorry about that, guys. All right. Can I just get a thumbs up if that's coming across? Should say upper cervical trauma. Looks like we've got the right talk. It looks like we're recording and we're sharing. So what we're going to cover over the course of the next hour or less is quite a lot. It's on cervical trauma. I'll spend the first probably 2/3 of our time talking about upper cervical trauma and the last third or so on subaxial trauma. What I like to do is make sure I stop about halfway through, just to make sure we get some time for some questions and answers in real time. If upper cervical takes us more time, we'll spend more time on it, and we'll come back to subaxial trauma in the future. But I think from past experience, we should be able to kind of get through it all. One thing I will ask is if somebody could just keep maybe Sri or Wellington, if you don't mind keeping an eye on the chat function, if there's questions that come up there. It's a small enough group that we usually just go camera on and sort of start speaking without worrying about cutting anybody off. But if that's not comfortable, people can enter stuff into the chat. So these are my disclosures. They're not related to the topic at hand tonight. So there's three things I want us to leave with our discussion tonight. Just one is an understanding of why we classify cervical injuries and how we go about doing it. We'll cover some of the more commonly reported classification measures, and then try to sort of give you a current state of, in 2021, where are we and how should we be talking about these problems or these injuries. We'll go across a strategy of sort of using classification systems to assess patients and then to drive decision-making. And then we'll go over at the very end, what are those key steps in that process of classification to decision-making in terms of trying to be evidence-driven in our decision-making process. So first of all, the why, right? Why do we classify? So as orthopedic surgeons, I think this is what sometimes it's just the thing we do, right? Why do we classify? It's because we're orthopedic surgeons. We classify everything. But hopefully there's a little bit more purpose to it. And specifically thinking about these injuries in terms of having a common language to describe the injury, both amongst surgeons, so communication between surgeons, between sort of professionals taking care of these individuals, but also honestly, just to describe them to yourself, right? So you get into a cadence and a framework of how you evaluate injuries reproducibly, and maybe drop down some of the noise in our practice and in our decision-making. So I think the biggest part of this is getting to a common description and the ability to communicate consistently. We also would love a classification system that predicts stability, right? We'd love to be able to differentiate stable from unstable patterns because that drives decision-making processes, especially for us as surgeons. And we'd love it if the classification system also was somehow prognostic, right? And could predict or help us identify what, or help patients at least even predict how they're going to end up doing from the injury that they sustained. So our first step, though, if we're going to talk about cervical spine tonight, is really just to make sure we're clear on the geography. And there's a pretty clear dividing line, and I'm going to put that right at the C2-3 disc, right? Where everything above that is upper cervical spine. Everything below that, we're going to call subaxial spine. And let's keep that division in mind because the anatomy of these two regions is strikingly different. The injury patterns are very different. And the treatment decision-making oftentimes ends up being very, very different between upper and subaxial injuries. So we'll start with upper first and then work our way towards subaxial towards the end of the discussion. So if we think about upper cervical spine, these are the concepts we're going to go through here over the course of the next, I'd say like 20 minutes or so before we stop and do some questions or some conversations. First is anatomy. We're going to spend a lot of time talking about the anatomy. We're going to go over certain injury patterns: craniocervical dissociation, occipital-condylar fractures, C1 fractures with transverse ligament injuries or without, odontoid fractures, and then traumatic spondylolisthesis. And the concept here is that we're starting with anatomy and we're literally working from cranial to caudal. So we're starting at the occiput and we're working our way down towards that C2-3 disc space. Okay. So the best way to think about upper cervical anatomy, O to C2, occiput to C2 anatomy, is that it's strikingly unique compared to the rest of the cervical, thoracolumbar spine anatomy. So what is unique about it? Some of it is the fact that if you look at from an osteology standpoint, there's not a lot of constraint in the upper cervical spine from the bone itself. Most of the constraints come from the soft tissues. Right. So if you think about why is that, well, there's a tremendous amount of motion that occurs in the upper cervical spine. And to allow for that, those extreme amounts of motion, flexion, extension, rotation, you need to have relatively unconstrained bony anatomy. So how are you going to support those unconstrained bony elements? You're going to have really tight, really strong constraining ligamentous structures. So what's the first one we think about? And this will feed into our discussion around occipital cervical dissociation, is the tectorial membrane, right? This thick cephalad extension of the posterior longitudinal ligament. And if you don't remember from anatomy labs, it's worth the next time we're in a lab looking at this and understanding really how robust and thick it is, in addition to the anterior supporting structures that go sort of up the anterior aspect of the Bayesian to the clivus. So it really forms the ventral foramen and magnum. It's dorsal to the C2, C3, even down to, C1 and C2 vertebral bodies. Then next layer down, right, we start with the transverse ligament, which will be really important as we talk about C1 injuries, C1, C2 ring injuries. But the transverse ligament, right, connects the dens to the lateral masses of C1. If you were to resect or flip that part of the cruciate ligament off, you'd see the alar ligaments, these sort of apical sort of ligaments coming off of the dens and either attaching to the occipital condyle or to the lateral mass. There's sort of two bands that go in each direction. And those come into play as we start to look at certain occipital condylar fracture patterns, or maybe even for some of the lateral mass type fracture patterns that we identify. So let's start with craniocervical dissociation. Again, we're going to work from cephalad to caudad, cranial to caudal. Craniocervical dissociations, they're actually relatively rare in the era of seatbelts and airbags, right? And hopefully stricter DUI type laws. We don't see them, I think, as common as they saw them in the 50s, 60s, and 70s when these were first really reported. They still happen though. They're historically thought of as a fatal injury, right? These are individuals who basically have a horrific dissociation of their skull from their spine. They have a very high cord injury at the site of injury, at the time of injury, and oftentimes won't survive because of those injuries, or maybe concordant injuries or concomitant injuries. But even those who make it to a hospital, about half the time, at least in the past, these were missed injury patterns. Now that's from the early 90s, which really reflects data from the 80s. So you're talking about a pre-MRI world, and maybe even probably in many places, a world before routine CT scans. So plain radiographs alone, really easy to miss these injuries. And that's a problem because these patients get worse over time. There's similar studies and some other ones out of Harborview have shown a substantial number of patients will worsen neurologically if their injuries are missed. And think about what we just talked about, those first couple slides, how much ligamentous injury is required to create these radiographs or these CT images that we're going to look at in a minute. You really have to have complete disruption of those stabilizing ligaments, as well as then the OC1 or even the C1, C2 articulation. In terms of classification, there's 3 different types that have been reported. The types really are not that important because really whether you talk about an anterior or a posterior translation, it's really just the direction that the skull is going relative to the spine. And a lot of that has to do with just how the patient's positioned. In these really unstable injuries, you can move the skull wherever you want it, with a pillow, with a towel, with whatever it might be. So it's not so relevant anterior or posterior as much as it is it intact or not intact? Distraction injuries, which are the type 2 injuries, can occur either at the OC1 junction or as in the lower left picture through the C1, C2 junction. So understand that that's a rare variant, but certainly can happen. How do we diagnose it? So radiographically, again, traditionally, we would use one of the older measures described as a Powers ratio, right? Which is where you draw this line from the Bayesian to the posterior arch of C1, a line from the Opisthian to the anterior arch of C1, and you use that ratio, right? And if it's more than 1, it's considered abnormal. That's a nice screening test. I certainly probably look at it when I look at a CT to get some relative anatomy positioning, but it's really overall pretty limited in usefulness. It's really only positive if you have the skull going anterior, right? So if you have a pure distraction play, that ratio may not change. Mathematically, it may not change. So there's some false negatives, not the most useful measure, but one that's still sort of reported. A better way, I think, to look at this in both radiographs and honestly, even in CTs, are the Harris lines, or the rule of 12, okay? So there's 2 lines to think about with the Harris line. The first one here in blue is the Bayesian dental interval, BDI. So it's a different distance from the tip of the Bayesian, which in x-rays are hard to see, but in CTs, you should be able to see them pretty reliably, to the very tip of the odontoid, okay? And that line is supposed to be less than 12 millimeters in most patients. If it's more than 12 millimeters, you likely have abnormality, meaning distraction, where the skull is distracted off the tip of the odontoid. The second number to think about is the BAI, Bayesian axial interval, and that's in orange here in this picture. And that is the distance from the back tangent of C2 to the tip of the Bayesian. And that's meant to just sort of describe anterior or posterior subluxation. And again, 12 millimeters of anterior subluxation or more is considered abnormal. The other things that we look for on CTs that key you into an occipital cervical injury are soft tissues. And there's no classification system for soft tissues. But if you see a lot of prevertebral soft tissue swelling, especially in this area, you need to have a high suspicion of a occipital cervical injury. So next thing to talk about as we work our way down are occipital condylar fractures. These are generally benign. They're almost always nowadays incidental findings on CT scans. So you'll get consulted on a trauma patient and they'll find an occipital condyle fracture. The most common ones are these type 1s, these little small comminuted type impaction fractures. May represent a partial avulsion of one of the check ligaments, but stable injury pattern. The other ones we'll see then are sort of larger fracture patterns that really are an extension of a basilar skull fracture. So you want to look through that head CT at times if you don't have enough of it on the cervical CT. But those are really the stable injury patterns. We treat them in a collar. You give them, 4 weeks, 6 weeks, come out of the collar, and healing rates are generally very high because you have a large degree of either you're not asking much on a type 1 or you've got a large degree of cancellous bone from a basilar skull fracture that tends to heal well. Type 3s are thought of as the unstable injury patterns. And this is one where you do see sort of a dissociation or a fracture through the occipital condyle. And this is occurs in you'll see it in maybe up to half of craniocervical dissociation. So if you see a type 3 occipital condyle fracture, again, index of suspicion gets pretty high for a bigger craniocervical injury. So those are the cranial injuries, OC1 type injuries. We're going to next move on to sort of C1, C2 injuries because they're a little more common. And then we'll stop for some questions. So one case just to show you, because I think cases help me at least remember things. So, this was a patient who had come to me in my office, 31 years old. He had actually was 2 months out from a motor vehicle accident. So 2 months removed from his injury. He had his cervical spine cleared at the index, but continued to have neck pain and really quite severe stiffness, very, very little rotational motion. And he had come to me sort of as a second opinion. And so, these were x-rays taken after the injury. So I didn't have the injury films themselves. But overall, you could see why they may have cleared his neck, at least looking at the standard sort of anterior longitudinal line, posterior longitudinal line, the alignment, soft tissue swelling, maybe not all that impressive. But remember, I think a good trauma series, if you're going to use plane radiographs, needs to include an odontoid view, right? You've got to see C1 and C2 with a lot of clarity. Nowadays with CT, you're going to get sagittal coronal imaging sort of automatically obtained. But if you're seeing someone in the office, go back and make sure we get these odontoid views in the setting of trauma. They're a little hard to see, teeth get in the way sometimes. But if you look really hard, you'll see, I think with a fair amount of clarity, where the lateral masses of C2 end and where the lateral masses of C1 overlap substantially. Okay. And so this degree of overlap cues us into a C1 ring injury. Don't worry if you can't see it on the x-ray. You spend some time looking at it. If you're watching the video, pause it and really take a look at things here. If you're looking at it in real time, I'll show you some CT images and some better diagrams in just a second. So C1 ring injuries, typically we think of these as mechanistically compression fractures. So some kind of axial load to the skull, maybe with varying degrees of lateral bending, flexion or hyperextension that may create fracture planes in different directions. There's 3 types of fractures to think about, and we'll go through these one by one. So type 1 fractures, which is the most common that we'll see, we call them Jefferson fractures. This is basically a fracture through the ring of C1, oftentimes leaving the ring in either 3 or 4 parts, just like ring injuries in the pelvis leave things sort of, if you will, in multiple parts. Usually multiple fragments. These are typically canal expanding injuries, right? Think about the ring sort of expanding. So very rarely do you see a neurological injury with it, okay? Which is maybe is part of why people think of these, maybe part of why these injuries were oftentimes missed is because they're neurologically intact patients. And this may be what a standard sort of axial CT looks like, overlapping an anatomic picture, seeing that sort of fracture line, 2 fracture lines anteriorly, at least 1, maybe 2 posteriorly, and then some displacement. And so when you get these fracture lines, remember basically what happens is the lateral mass on the left and lateral mass on the right are no longer in continuity, right? That bony continuity is gone. So the only thing holding it together is this transverse ligament, which is sort of highlighted in green here on the cadaveric slide. And if you have enough spread, if those fragments, left side of C1, right side of C1 spread enough, you can attenuate the transverse ligament, or you can frankly disrupt the transverse ligament. And that's what leads to an unstable Jefferson fracture. So Jefferson fractures with the transverse ligament intact are stable. Once the transverse ligament is gone, they're unstable. And I think that's a really important differentiator. That's fair games for OITE. That's fair games for boards. And honestly, it's an important thing for us to understand in the management of these patients. We've seen some really, really bad missed injuries over the course of my career because of lack of understanding of this. So if you're looking at this AP view or coronal view, right, and the C1 lateral masses are spreading apart, and the transverse ligament tears, you're going to have a subluxation of the C1 facet on the C2 facet, right? And in the diagram on the left, I think that's really clear where you see this overhang. C1 is overhanging C2. And that's sort of what I'm trying to draw for you on the x-ray as well. Again, it's a little tough to tell, but if you look at the anatomy side to side, you'll start to see where the C2 facet joint ends, the C1 facet joint ends on both sides. One side's a little harder than the other. There's a study, anatomic study, from which we derive this thing called the rule of Spence, if you've heard of it. So here it's 7 millimeters is the magic number to remember, 6.9 technically from the paper, but 7 millimeters. If there's more than 7 millimeters of overlap on CT, then you're going to have a situation where you've got a likely disruption of the transverse ligament. And maybe with X-rays, it's 8 millimeters based on some magnification error from the X-rays from at least one study. So once you see too much overlap, be aware that the transverse ligament might be disrupted, which leads to an unstable injury pattern. The other type of injury pattern for C1 ring fractures that oftentimes creates instability and oftentimes is overlooked are the type 2 fractures, where you have the fracture basically resulting in one of the lateral masses being completely detached or dissociated. And you'll have a lot of rotational and angular instability through that facet joint. Transverse ligament may or may not be disrupted in this setting. But what does happen is that entire pillar, occiput C1, C2, is no longer intact. And what will happen is patients will gradually drift. Their head will gradually drift into a coronal tilt with some of these type 2 lateral mass fractures requiring, fixation and stabilization. Type 3 injuries are sort of considered to be benign. These are stable injury patterns, posterior elements only. Always want to look on the CT to see if there's an anterior ring component. Sometimes these will actually be incomplete consolidation, right? If you look at the C1 ring and how it forms and how it ossifies, you can have some discontinuity in ossification that can be developmental. And so at times you might get called for a C1 fracture and you look at it and it sort of looks chronic. It looks like, corticated edges, maybe blunted or rounded edges. Keep in mind that might just be developmental anomaly and not an acute fracture. This, I think, dovetails into a discussion around C1, C2 instability. I have seen this only one time as a traumatic disruption of the transverse ligament without a bony component. I've only seen this once, but I'm sure it can happen, where you get injury resulting in C1, C2 instability because the transverse ligament is torn, but there's no appreciable fracture itself. And the numbers we go with there is somewhere around 4 millimeters or 5 millimeters being considered unstable. This is similar to what we think about with rheumatoid patients, right? That can develop C1, C2 instability from erosive disruption of the transverse ligament, or similar to what we might think about in certain Down syndrome patients who can develop C1, C2 laxity. So can happen traumatically, hard to detect in the acute setting, but this is where your maybe 2-week, 4-week post-injury flex X films can be useful to look at the DENS. So last couple things to talk about. Now we've gone from occiput to C1. Now we're at C2. Odontoid fractures, super common, right? They're probably at least 10% or so of all cervical fractures that we see. There's a really interesting age distribution here. There's these young, high energy fractures that you'll see usually coming out of substantial falls or motor vehicle collisions. And then you get the older patients with low energy trauma, right? To where you're now talking about, is this really a fragility fracture that we think about differently than the young, higher energy odontoid fractures from a treatment standpoint? Classification, the most commonly described system is the Anderson-Alonso classification system. It dates back quite a ways, as you can see. And we'll go through these one by one. Type 1 odontoid fractures are really just a very, very tip of the odontoid, or maybe an oblique corner of the odontoid. And that's thought to most likely be an avulsion of the alar ligament attachment. If you remember, we go back to one of those first slides about those alar cruciate ligaments. So maybe you get a little fleck of one that pulls off. Again, think about the possibility of cranial cervical dissociation in this setting. Look for soft tissue swelling, look for the Harris lines. But generally, these are oftentimes incidental findings, minimal symptoms, a brief period of time in a collar, and then really relatively rapid immobilization is all they need. Type 3 odontoid fractures, I'm going to skip 2 because that's where the meat of the conversation is. Type 3 odontoid fractures. Now, on the sagittal view, they'll look like they're a little bit lower down than type 2s, although it can be close. So the real differentiator is that these fracture lines run into the C1, C2 articulation. So somewhere along the path, you'll see the fracture line go into the C1, C2 joint. If it does, it's a type 3. These are stable injury patterns, lots of cancellous surface to interdigitate, provide some internal stability and good healing. If it doesn't go into the joint, then you're probably really dealing with a type 2 fracture, okay, at the very base of the dens. And sometimes these 2s and 3s get really close to each other. So really look at those coronal views and decide if it's in the fracture, if it's in the facet joint or not. So when we look at odontoid fractures, we think about them, these type 2 fractures, as being the ones that are at the greatest risk for displacement and non-union, right? We think of them potentially being in a bit of a watershed area for vascularity, but also creating C1, C2 instability, right? Because you've now dissociated C1 from C2. The peg, the odontoid can go anterior, it can go posterior, it can angulate, right? Those are all factors that we consider at least as potentially cluing us into stability or instability. There can be comminution of those fracture patterns, which becomes relevant when you think about fixation options. And so relatively severe comminution and angulation are rare. It's rare to see a cord injury with these because, again, these are generally going to be canal expanding, except in extreme examples of instability. So this was a patient of mine from early in my practice. He was 78. He was riding on an ATV and intoxicated. It's always a nice combination of like testosterone, alcohol, and gasoline that leads to so much work for us, right, in our careers. But he had a flip rollover, you know, came in neurologically intact. And as we look at his CT image here, I want to hone in again. We always look at everything, look at the entire cervical spine, but we hone in on the odontoid. And yep, there's a little bit of fracture comminution. And yep, it's sort of a transverse type pattern. But I think the real crux of this is to look at how much displacement there is, right? The peg is almost 100% displaced off the odontoid. And that's just a sign, again, of how unstable is this injury pattern, that you get that much motion. We'll see other odontoid fractures with very, very minimal instability. You look in the literature, some studies will talk about, you know, a centimeter of motion. Some people will use 5 millimeters of motion. Some people will use angulation, 10 degrees, 15 degrees, 20 degrees. Unfortunately, none of those thresholds, at least to my knowledge, are validated, right? So we have to think instead about, is it displaced or not displaced? And almost use it as a Boolean, like yes, no, right? And then you start to think about the patient's age in terms of, are they a high risk of non-union, low risk of non-union? And that oftentimes will drive our decision-making about surgical fixation or not. There's a lot more to talk about with regards to odontoid fracture treatment and management in terms of the decision-making. I don't want to gloss it over too much, but I think from a classification standpoint, that's a pretty good place to start. Once we've decided if they're stable or unstable, if they're unstable, we can drive towards surgical management. There's lots of different ways to fix these surgically. Anterior odontoid screws, back in the day, posterior wiring. Nowadays, for most of us, it's segmental fixation, right? Screw-based fixation, C1 and C2. And that's what this patient had, was C1, C2 fixation with some onlay grafting. Last thing to cover in the upper cervical spine, C2 fractures. You'll hear these called hangman's fractures. And the classic example is a fracture line basically through the pars of C2 bilaterally. And you'll hear this also called a traumatic spondylolisthesis. That's a nice way to think about like a pars fracture, right? Bilateral pars fracture. Typically a younger patient population than odontoid fractures that falls more in line with higher energy trauma, oftentimes car accidents. It used to be thought this was a combination of axial compression and hyperextension that would sort of stress the pars and lead them to fail. So it's oftentimes was described as a windshield strike. If somebody comes in and they've struck their head hard against the windshield, you know, maybe that's a risk for a C2 fracture. Again, neurological injury, not entirely unheard of, but really rare, because again, this is a canal expanding lesion. Okay. The one thing that I will say from clinical experience, and we're going to go through some classification examples, it's pretty rare to see a very clear fracture pattern that just goes through the pars. You can find them from time to time, but oftentimes one side will be through the pars, the other side will be through the vertebral body. So don't, while this is a good picture to have, don't be surprised when you're looking at patients if it doesn't quite fit the mold. So there's a couple of different types that have been classified, again, going from stable to unstable. So type 1, very, very little displacement, less than 3 millimeters of displacement across the fracture site. Critically important here, displacement's minimal, alignment looks normal, and the 2-3 disc, the disc itself is intact and hasn't been disrupted. And we'll see as we go along the spectrum of instability, you see more displacement, you see more angulation, and you see the disc gradually become involved in the injury pattern. Type 2 injuries, the thought is the PLL is likely disrupted here. You get a little bit more displacement. You start to get more angulation as well. But again, these type 2 injuries are generally thought of as ones that can be reduced and maybe held in reduction with a halo or with a collar potentially to try to treat these as closed injury patterns. Type 2A is where the angulation gets a little bit more, right? So you're talking about typically more than about 20 degrees of angulation. You'll oftentimes see disruption of the C2-3 disc as well. So the disc will look distracted, right? Or you'll see some frank translation through the disc itself. These are the unstable ones. These are the ones that are going to require surgical intervention, at least in my practice. There is some reports of treating these with a halo, reducing them, getting them reduced, holding them in place with a halo. But once the C2-3 disc is gone, these become very, very unstable injury patterns, and I think very difficult, if not impossible, to manage consistently, with a halo. Type 3 is the next iteration where not only do you get this massive angulation, this disruption of the disc, it actually gets so bad that you actually dislocate the facet joint in addition. This is something that you can't reduce close. You have to open them to reduce it. There's no way to get traction and affect that posterior element, right? Because that posterior element of C2 is no longer attached. So these are ones where you've got to open them, reduce the joint, and then reduce the fracture as well. One thing that likes to show itself on the OITE, on the boards, is a Hangman's variant. And this is what I was hinting at earlier. More common than you think, actually, to get these varying patterns where it's not just a clean cut through the pars on both sides, but a little bit oblique, a little bit atypical. This can cause, this really bad atypical pattern can cause a cord injury. And that the reason that people like to ask about it is that it lets you ask for a specific cord syndrome, the Brown-Séquard syndrome, where you got basically a hemicord injury, right? So you'll have ipsilateral motor loss, contralateral sensory loss. So that's where Brown-Séquard comes up. It's nice to show on a test. Don't be surprised if it pops up as an injury pattern. And then just as a summary, the AO has a really good website and a really good summary of their classification systems. This is just, again, so you guys have it for the future, pause it or screenshot it. And you've got the ability to go through that same pattern of injuries that we just went through, starting at the occiput, C1 ring and C2 and C joint, and then going down to C2 and C3. They've got some additional modifiers about neurological impairment. And then, like the AO does, they've got this type C, 1, 2 with this modifier sort of classification nomenclature that I don't know how to use. In 15 years, I've never figured out how to use it in my practice. But clearly some people think it's really important. So I'll mention it so you guys are aware of it. Let's stop there before we get to subaxial. That was about 30 minutes. And what's questions you guys have? What have you seen? What are you not sure about?
I have a question. Are you regularly getting these odontoid views in your clinic when someone comes in with a, like their first workup for a fracture?
Yeah, so for like a standard degen patient who's coming in with neck pain, I would not get it. I think there's very little utility. In somebody who's coming to me for a fracture follow-up or first evaluation after an injury, I would. Oftentimes, again, nowadays, we're going to make sure we get a CT as well. But when you're in the office, it's a nice screening tool.
Dr. Patel, I will say that if I'm driving intoxicated on an ATV when I'm 78, I might consider that a win. That was a pretty impressive injury. But for the odontoid fractures, you mentioned with the C2 pars, we talked a little bit about halo treatment. Is there any indication for halo treatment in the odontoid fractures? Are you still doing that in your practice, or is that more historical?
Yeah, I want to let Divi and Sue chime in after I give my answer. I personally feel like it's historical, with one caveat: younger patients with who are maybe a lower risk for non-union, it'd be reasonable, I think, to try a halo in that population to try to mitigate or avoid, some of the downsides of surgical fixation and stabilization. So if you can get them reduced and hold them reduced, that's pretty reasonable. In the older population, I just don't think they tolerate it at all, right? There were a couple of articles that talked about, now they're not great, but there are a couple of articles that talked about morbidity, mortality from a halo in the older population. So I've moved away from it because I think it probably causes more harm than good. But I'm curious, Sri or Wellington, what do you guys think?
Yeah, I haven't used a halo in, I don't think I've ever used one at Northwestern, actually. And I would agree that it's really the young patient who doesn't want surgery at that level where you consider one. But I think there's so many social sort of aspects that come with it that most patients would, if you give them an option of a C1-2 fusion versus a halo, they'll actually just go with the C1-2 fusion. So yeah, I know we have those services here. I just can't remember the last time that somebody had to use it.
Yeah. We had someone pop into our office on Tuesday with a halo that was put on somewhere in Wisconsin. And it was a reminder, we don't have any of the equipment around to take those off even if we wanted to. So that's how infrequent.
Yeah, that's right. We used to have like a screwdriver for the
Yep.
halo on every floor, like in every spine room, essentially, just in case that we were stuck with that.
Yeah. I mean, I remember when I was an intern and even as a student, we used to, in our pocket, always have the halo screwdriver because those patients would always show up in the ER with pins that were loose or, pins that needed to be tightened. Sri, how about you? Did you use any halos in your fellowship?
Hey guys, sorry, still scrubbed in. I think the only Halo application I used was for deformity. So patient with like severe kyphosis, kind of Halo to stretch them out before surgery, but I'm not for trauma. I've reduced, I'm trying to think. No, I've left people in like traction overnight to try to get them. Again, that was for deformity too, not for actual trauma. So no, I have not, and I don't see that coming up that often either.
Yeah, it's definitely an art that's sort of going away, right? Yeah.
What are your thoughts on when is the appropriate timing to do a flex X view on someone who's following up for trauma?
That's really good. So I think Wiley, I just make sure everyone knows who you are. Wiley's one of the Rush Fellows who's joining us.
Hi, everyone. Thanks
Sorry to introduce you earlier. We're going to have hopefully the guys from Rush joining us for the lectures and a couple of their faculty speaking a little bit later. So I will tell you my protocol. If they're coming in the ER, they've got basically a negative workup, right? Radiographically, but they still have neck pain. We'll keep them in a collar, bring them back in about 2 weeks. Collar comes off, and then I'll check Flex X films. It's pretty rare between for CT scans to miss injury patterns, right? So it's tempting to want to just take the collar off in the acute phase when they're in the ER. But I just don't think that you gain much by doing that other than a little bit of inconvenience for the patient. You just add some risk to the conversation. There is a way to clear people's cervical spines with MR. And if they're really like obtunded, you can, do Flex X fluoroscopy in real time if you have to get the collar off for the acute trauma patient, but 2 weeks. One thing that's for sure useful or completely useless is the acute Flex X film. Doing Flex X films in the ER is a complete waste of time. Other questions, thoughts, guys? I'm going to swing us over to the other, to subaxial spine, but jump on in if you need to. All right. Same thing. I should get a quick thumbs up if you guys can see My screen looks like we're on. Okay. So subaxial trauma. So upper cervical trauma is like a lot more fun to talk about because it's unique anatomy, they're unique presentations. They're obviously a lot rarer. So they're probably maybe not as practical. This should be the practical half of the conversation today, which is the what are things that you're much more likely to see on any given night. So subaxial trauma, we went over kind of what our goals are here. We went over the geography again, except this time we're going to be on the bottom half, right below the C2-3 disc. And I think for all intents and purposes, for most of our conversation, we can think of C3, 4, 5, 6, and 7 as essentially being the same. As we get into the upper thoracic spine, maybe it changes a little bit because the supporting structures are different, but the same concepts. We're still expecting a fair amount of mobility, right? From rather from C3 down to C7. So the osteology has been designed to allow for a lot of flexion extension, a lot of rotation, and even a fair amount of lateral bending through these joints. So the ligamentous structures, the integrity of the disc, the integrity of the ALL, PLL, posterior facets ends up being really, really important. Unlike the thoracolumbar spine, there's really no posterior like ligament, if you will, right? There's no supraspinous ligament that connects these segments together. When you're doing these cases posteriorly, if you look, it's all just muscle attachment from one segment to the other. So it's not so much like the TL spine where you've got this really thick band of supraspinous ligament. So really ligamentous control for the spine ends up being very much segmentally driven as opposed to maybe more globally driven. So this was another old patient of mine. And maybe I'm going to call on, I saw Steve Devlin on the line, who's our junior resident. So I get to call on him. This is a case, again, old patient of mine, 48-year-old snowboarder, hit a tree, came in with neck pain and left arm pain and numbness. So Steve, what do you think about this x-ray?
So just looking at alignment, first of all, the lordotic nature of the C-spine is maintained. If you're looking down at C2, 3, 4, 5, it looks like C5, there could be a compression fracture type fracture at C5. It looks like there could be, and there's some ossified pieces off the anterior aspect of C5. Mm-hmm. So thinking of maybe some ligamentous avulsion fracture around C5.
Okay. What else do you think about the film? If I told you C5 is normal, because those are just arthritic changes because the guy's over 40. Is this x-ray enough to clear someone?
No. Why
is that?
I don't think you just get good enough detail with the x-ray if they're still having pain.
Mm-hmm. There's something more specific about this x-ray that's lacking. What do you think? Who wants to help him?
You can't see C7.
Yeah, you can't see C7, you can't see T1, right? So Steve, when you're looking at a film, you hit all the right spots. Lordosis looks good, right? This anterior vertebral line, posterior vertebral line looks good. Spinal laminar line looks good, right? So all the lines look good, but you can only see C6, right?
Okay.
And so then if you get a swimmer's view on the same patient, I'm going to tell you that C5 is about here where you saw those little osteophytes. C6 is right here. And if you look, now you've got this translational step off. Right. So just to hone in on the idea that in an era when we use plain films only, which still happens in a large part of the world, you really have to have good, high quality plain films. So nowadays, what we oftentimes would start off with is this, right? You'd start off with a CT before you ever even saw an x-ray. So if you look, Manish, I'm going to tap you on the shoulder as our chief. I gave you some slices here. Some of them are good quality, some of them are bad quality, kind of like our CTs in real life. What do you think's going on here? What do you see in terms of abnormalities?
So it looks like here you can see some 6-on-7 and tearlesthesis. 2, 3, 4, 5, 6, 7, 2, 3, 5, 6, 7.
So you're right. There's
on the right.
I got the right and left mixed up here. Sorry.
Okay.
The left is the right side. The right is the left side.
Right. So on the one on the right, it's listed as the right, but it's the left. It looks like there's a pars fracture there. That's giving rise to that.
There could be a little fracture there. What I want you to hone in on is look at the facet joint. right? That's the right side, not the left side. And then if you look at the axial of that level, you'll see the facets sort of sitting on top of each other, kind of in a weird pattern, right? So 6-7 is translated. There's something going on with the facet joint. I told you he's got neck pain, he's got arm, and he's got arm pain as well on that side, right? So if we think about it, I just like this slide because it's just sort of funny to think about these things as hamburger buns, but it's not a bad analogy to think about what should a normal facet joint look like in the cervical spine versus a dislocated facet joint. Okay, so a normal facet, like on the left side, you see sort of the cranial and caudal, or the SAP and the IAP in flush contact with each other. And on the right side, in a dislocated manner, you see one having jumped over the other, right? And that's where this idea of a reverse hamburger bun sign comes. It's almost like the thing's inverted in a position it shouldn't be in. But if you see that on a CT scan, if you see that on the axial view, you want to just be a little skeptical what's going on. Most of the time, these facet subluxations are pretty obvious, but sometimes they can be kind of subtle, especially ones that have a tendency to dislocate and then partially reduce. You'll see some subtlety on the axial CTs there. So in terms of classification for subaxial injuries, and we're going to get back to that case in a second, but if we look at subaxial injuries, there's a couple of classification systems historically. If you go back far enough, Ferguson and Allen, from the 80s, talking about mechanistic types of classification systems. We published this one about 12 years ago or so, breaking down injury patterns a little bit differently and thinking about neurological involvement. I'm going to go through this one, and it's very similar. There's a lot of overlap with the current AO system, so I'll make sure we also have the AO system up for comparison in just a minute. But I think the real benefit of these newer classification systems when it comes to subaxial injuries, back to this concept of common language, common frameworks, is that it breaks up subaxial injuries into one of three critical characteristics. One is the injury morphology. So what type of an injury morphology are you dealing with? Second is what's the integrity of the disc and the supporting ligaments, the disco-ligamentous complex. And then the third thing is what's the neurological status of the patient? Because these are the three critical factors in determining stability and instability, and then determining what our management is going to be. Not just what our management is going to be, but how rapidly do we need to enact that strategy. So we talk about injury morphology. There's compression, distraction, translation, rotation. Those are the three morphologic patterns. Compression is a morphology where you can imagine like an axial load, right? So you may just get, like in the top two images, compression patterns, or you may end up actually with a cervical burst injury, okay? These bony anatomy that you're seeing here may be associated also with ligamentous injuries. So sometimes these bony injury patterns will actually represent a much more unstable injury pattern. That's the classic teardrop fracture, where people call it like a small chip off the anterior body, but there's actually quite a bit of ligamentous injury associated with it. So just because it's compression morphology doesn't mean it's benign, but oftentimes these are more benign injuries and can be treated, non-operatively. Even burst fractures, right, can be treated non-operatively. Distraction injuries, which the AO now calls tension band injuries, are ones where you have some axial distraction, right? And either the anterior or the posterior tension bands disrupted. If it's a posterior disruption, we think of it as a flexion injury. If it's an anterior injury, we think of it as an extension injury. But the fundamental common thread there is that this sort of like an axial distraction. And then the last one are these translation or rotational injuries, like the one we just talked about, where you've got one facet that's jumped over the other. And because of that, C6 in that case is rotating off of C7. You'll see it as a translation on the lateral X-ray or on the sagittal CT, but it's actually a rotational deformity. So then with the discal ligamentous complex, at least the original classification put these as either intact or disrupted. And then they put a big gray zone in the middle of intermediate. Not surprisingly, a lot of people end up saying it's intermediate because you're not quite sure, right? The best way we can assess this is with, certainly CT can give you some insights, upright X-rays. So you'll see a lot of times before we discharge somebody, we're not sure, we'll put them in a collar, get an upright film and see if we see motion. Or you can rely on MRI maybe to get ideas of interspinous widening or interspinous disruption, like I'm showing you here with this arrow. The MRI is both good news and bad news, right? It's highly, highly sensitive. It'll pick up everything. Unfortunately, it's probably too sensitive and not specific. So you'll get a lot of noise. You'll get a lot of random sort of edema patterns posteriorly in the soft tissues or in the musculature, but those won't necessarily determine if it's stable or unstable. So the way I look at an MRI is a normal MRI has probably a very high negative predictive value, but a positive MRI does not really have a very high positive predictive value. So it's not bad as a screening tool if you want to clear someone's neck, for example, with an MRI, but it's not great, to hang your hat on for a firm diagnosis all the time. Sometimes, like the picture on the right, it's pretty obvious, but oftentimes in that setting, you've got other clinical findings, either neurological findings or even CT findings that suggest instability. And then with neurological injury, let's just think about the pattern here. Is it going to be a root level injury or a cord level injury or some combination thereof? Unlike upper cervical spine, where you've got lots of space and a lot of those injuries create more room, subaxial spine, generally you're talking about canal occupying or foraminal occupying injuries. So you're not uncommonly going to see cord injuries or root injuries with it. And we have to remind ourselves there's going to be some confounders in the subaxial spine. The ones that we worry about the most are probably dish and ankylosing spondylitis patients. Remember, those are fundamentally probably different injury patterns. But we also should think about osteoporosis. We should think about severe spondylosis when we're thinking about how much or whether we should intervene and how much fixation is going to be needed. And as I mentioned, the AO subaxial injury pattern or subaxial injury classification system also exists. It takes a lot of those concepts that we went over of, type A or compression, type B or tension or distraction injuries, type C or translational injuries. They added some interesting, unique modifiers around facet injuries in particular, talking about non-displaced facet fractures with possible instability, and then ones with floating lateral masses where the lateral mass is detached, or ones with frank dislocation or translation. So facet fractures, it's really this F2 facet fractures that may or may not be unstable are the ones where you have a really hard time with clinical decision making. And oftentimes that's where, again, an upright X-ray helps you figure that out, right? Gravity is a really effective deforming force. So if you use it to your advantage, it'll help tell you if these are stable or unstable injury patterns. And again, the website's on there. These injury classifications are on there to be able to download, to keep as well. So you should have access to all of that. So let's go back to this case. We talked about this being a translational injury, right, Manish? We talked about the right-sided, C6, C7 facet being dislocated. And we talked about a guy who's having neck and arm pain, right? What do you think's causing his arm to hurt?
Where in the arm is it hurting? Or is this radiculopathic?
So it's arm pain. It's radiating radicular arm pain. It's probably down the back of the arm, posterior arm, past the elbow, maybe some numbness into the long finger.
Okay, so I think it's probably there's probably some compression of the exiting root here.
Which is which one?
C7.
Right, C7 root.
7 under 6.
From that facet being jumped over, right? C7 root is probably living somewhere right around here where you've got this facet dislocation. So in terms of MRI, this is this patient's MRI scan, right? Where you see, I think here, you've got some noise, sort of this bright white material all posteriorly, like right underneath the skin, under the fat, noise, but you've also got probably real signal here within the sort of interspinous space, suggesting at least disruption of those muscles that connect C6 to C7 posteriorly, maybe even disruption of the facet joints as well. I think there's a strong argument to be made that, did this patient really even need an MRI? Like, did I not have enough information from the CT to drive treatment? But yet, reflex oftentimes nowadays is to get an MRI. I understand we might not always need it, right? The one reason I use MRIs in this setting, in this case, this is somebody that I did an awake reduction on, which is my next slide here, right? You put them into tongs and you can use either bivector traction or honestly just your own hands to take this injury and reduce that facet back. Okay, another conversation for another day about how we go about doing that, but you can close reduce these injury patterns. And if you're going to do a close reduction in a subaxial injury, especially in somebody who's neurologically intact, I think you want to know if they have a disc herniation or not. Because there are some case reports, one case report really, of taking somebody, reducing them, and creating a bigger problem because of a disc herniation, associated probably with the reduction maneuver itself. So that's where we got an MRI in this case, was to aid us in the reduction. This patient had a reduction, and then ultimately I fixed him, posteriorly a day or two later. So we got a couple of minutes left. Last case. This was a 42-year-old who was riding on a riding lawnmower that rolled over. I don't know how you roll over a lawnmower. I don't know how you do it, but I'm assuming it involved a lot of bad luck as well as some bad, surface terrain. Unfortunately for this guy, was found down, don't know really quite how long, non-responsive, and he had essentially zero motors in his upper and lower extremities. He had no sensation. He had no rectal tone, and was acutely hypertensive. So Steve, you're back on the hot seat. Manish, you're off for a bit. So if I present that injury, let's get to the x-rays in a second, but if I tell you that neurological pattern, right? What is that? What type of a cord injury does that classify it as?
It's a complete injury, so it'd be an Asia A. He'd be in spinal shock with his hypotensive, absent sensation, things like that.
So let's be really clear. I think you got the first part spot on. It's Asia A, right? Complete cord injury, no sensation, no motor, no rectal tone, right? So if he's hypotensive and he's in shock, what kind of shock is that?
Neurogenic shock.
Neurogenic shock, right? What's spinal shock?
It's what you can see in shock when the cord is not getting perfused, and then you get similar presentation with the absent sensation. You get absent reflexes, absent rectal tone, but due to hypoperfusion of the spine.
So you're close, but I want to tweak that a little bit because this is also fair territory for the OIT, fair territory for the boards as well. Okay. Your first part was spot on. Hypotension, that's shock, right? Trauma principle 101. In this setting, it's neurogenic shock because of a loss of the normal sympathetic tone, right? Normal sympathetic pattern. Spinal shock is the actual think of it as sort of the actual concussive event that the spinal cord is still going through. It's not really shock in a trauma sense. It's not related to blood pressure. It's the idea that the spinal cord has sort of been stunned. And the best way to assess that, probably the best way that we have, one is time. We know that in the acute setting, it's more likely to be present. But there's an exam finding that we think about that maybe correlates to spinal shock. Do you know what that is?
The absent bulbocavernous reflex.
Yeah, so the bulbocavernosus reflex is the one that we think about, right, as being a signal of shock. So if someone doesn't have that reflex, it's a sign that they're in spinal shock, which means that their examination, might not be as bad as what you see, right? Once that stunned effect, if you will, the cord resolves, you might find that they actually have some preservation of motor function. Okay, so let's make sure we understand the differences there. But here you've got another, reverse hamburger sign in the bottom left here. You've got translation of almost 100%, right, of C4 on C5, so highly unstable injury pattern with dislocated facet joints posteriorly. We talked about the cord injury. We talked about the spine injury. We're almost out of time. I'll leave this on here again. If someone needs to pause it or wants to screenshot it, you can keep that for your records, talking about what are the different Asia classifications. We'll talk more about this as we talk about thoracolumbar injuries in the week to come. But to make sure we wrap this case up before we wrap up everything, the next step in this setting also is a bit of controversy, right? There's lots of ways to try to manage this patient. In the setting of acute cord injury with cervical instability, there's pretty good evidence that suggests the faster we get these patients decompressed, the better, right? Whether that be surgical decompression or reduction decompression. This was a patient that nowadays I might think about just taking straight to the OR, assuming the ORs were available. But early in my career, I couldn't always count on the ORs to be available. I couldn't always count on, getting access to them in a timely manner. And in my training, we reduced all these all the time. So I think early in my training, I reduced all of these in the emergency room. So that's what this patient had done. He had a closed reduction, Gardner-Wells tongs. There's a lot of discussion we can have around, should you get a pre-reduction MRI or not, right? In a setting with a complete cord injury, there's not much to be gained by waiting. And even if there was a disc herniation there, the reduction's unlikely to create more harm. So I try to reduce these patients as fast as possible and then get a post-reduction MRI. And if you look at his post-reduction MRI, everything's lined back up again, massive edema in his cord, right? Consistent with his injury pattern, and a disc herniation, right? So he's got now, this is a pretty good example of a disc herniation that either existed from the injury pattern or came about as a result of the reduction. But critical importance of the post-reduction MRI here is that in this setting, if you were to try to treat this patient posterior only, you'd miss a pretty large anterior disc herniation. So in my hands, at least, this was a front back procedure. Okay, lots to talk about. There's probably more slides than I can go over in the time we allotted. For the summary thoughts on subaxial trauma, really assess the neurological pattern really well, understand what's going on neurologically, because that's such a weight of decision-making. Look at the CT, X-rays for morphologic patterns, compression, distraction, translation, and then use the MRI as you see fit. Use it judiciously and with good questions in mind, not just routinely getting an MRI on everyone with neck trauma. Goals of treatment, neurological preservation, so early decompression and stabilization is sort of the mantra with most subaxial injuries that are unstable and need surgical intervention. Let's spend a couple extra minutes. I know we're over on time, but I want to take any questions you guys have about subaxial trauma.
Hey, Al, great talk as always. Man, really good summary. I know we got some junior and senior residents on the line. In your years of trauma call, if you were to assess commonly missed radiographic, I guess, assessments from a junior resident, if they were to call you about a fracture, and then you have the one impression, and then you look at a CT scan, you have a completely different impression. What are the most commonly missed issues or characteristics?
That's a great question, Wellington. I would tell you, I think we oftentimes will hone in on the bony elements of an injury because we're orthopedic surgeons, right? That's what we think about. And so in doing so, we'll see the trees really well. We'll see every little fracture fragment. We'll talk about a facet fracture here or an anterior compression fracture there. But we tend to miss the big picture in terms of alignment and sort of translational injuries. So I would say we pick up the small details, we see the trees, but we miss the forest sometimes. And the best example I'll tell you is with facet fractures. It's not uncommon to see a facet fracture that I'll see described to me as, a displaced facet fracture. But then you look at the images themselves, and there's actually quite a lot of translation, right, in the vertebral bodies. And those are patients that at time zero, I probably would have put in a traction. Even if you weren't going to take them to the OR that night, I put them in traction overnight and at least reduce them, let them get back to normal alignment, and then stabilize them, as you see fit later on, as opposed to staying in a collar, being subluxed, overnight. That's probably the most common error that I see. How about you, Wellington? What have you seen the most?
Yeah, I would say two things. Discal injury is one that can have a huge impact on the stability of a segment, and associated degenerative /dish/AS changes in the spine that can dramatically alter someone's management for the same fracture, as opposed to someone without any of those changes. So yeah, those things and they've been proven in the literature too, that they're commonly missed by radiologists and that sort of thing. So those would be key things to hone in on.
Yeah, that's a great point, especially the idea of those patients with ankylosing spondylitis or DISH, right? Those are fundamentally different scenarios, and we have to think about those injury patterns very differently.
Hey, Dr. Patel, sorry, I'm a little late to the call, but I don't know if you talked about central cord syndrome, but I just wanted to get your thoughts about how to think about when you do something acutely in terms of decompression versus watching and waiting to see if they improve and then doing something? Is it just MRI findings, acute findings, or what is it for you?
Yeah, so actually I had to just look all this up for the CSRS. I'm giving a talk at CSRS in a couple of weeks on this exact topic. And so if we think about central cord syndrome, there's two concepts we first have to think about. One is, if you tell me central cord syndrome, that's a very, very specific neurological injury pattern, right? Then other times you tell me central cord syndrome, and really what you're saying is somebody with a spondylotic stenotic neck who has some type of cord injury, probably incomplete, but doesn't have a fracture, dislocation, instability, right? And I think most of us, when we talk about central cord injuries, it's the latter, right? It's the older patient with a hyperextension injury and some type of an incomplete cord, as opposed to that sort of pure classic central cord syndrome. So if that holds true, what I would say is in that setting, it's really difficult to predict based on any imaging finding, MRI, CT, whatever, which patients are going to have a relatively rapid resolution of their neurological symptoms and which ones are going to go and linger on and maybe need to be decompressed. It's really hard to distinguish that up front. So I tend to, because we've tended to treat all cord injuries much more aggressively, rapidly, early, I tend to take central cord injury patients and probably treat them more like an acute cord injury, like a traditional acute cord injury, than like any subset or some unique injury pattern. The exception being is the patient who comes into the ER with a deficit, and during the process of workup, which takes hours, right? In that process of time, if they're getting better, their motor function is objectively improving over time. In those patients, I'll wait and maybe I'll watch 24 hours, 48 hours with pressure support, in the ICU to see if they do improve substantially on their own, especially if they're older or sicker or have a lot of medical comorbidities.
I was just going to ask if age played a factor in it for you.
Yeah, I think it does, right? But only in so much as it's surgical risk.
Comorbidity, okay.
Right. So if they're 80 but super healthy and really active, I oftentimes will tend towards maybe more aggressive treatment, like getting them in even earlier, versus maybe somebody who's older and maybe cognitively isn't fully there or has a really sick heart and may not tolerate anesthesia. And maybe you tend to tack towards non-surgical management, at least at first.
Okay, thanks.
Wellington, what do you think?
Al, I think that's a really great distinction you made, because when you say classic central cord syndrome, what you're referring to is the individual with normal, or let's say just say near normal lower extremity strength and very debilitated or absent upper extremity strength. And that's a very small subset of the people we see that we typically say central cord syndrome. You are absolutely correct that most people present with upper and lower extremity dysfunction in the absence of a fracture in the setting of cervical stenosis. And I would agree, I would treat that more as an incomplete spinal cord injury. Whereas the classic central cord syndrome, those patients almost always improve to a certain degree. Now that degree of improvement is variable in terms of the timing, but for somebody with classic central cord, I at least in my hands, I'm certainly looking for an excuse to do conservative care rather than go right away to the OR.
Yeah, I think that rings true. And the literature shows that also. There's an unbelievable amount of confusion about what it means to have a central cord injury. Like, it means different things to different people, right? And so we actually have a Yellow Academy article that we're putting through print right now, trying to sort of define this a little bit better. And the term I've liked that I've heard a few times is acute traumatic myelopathy, right? So this idea of, it's not a pure central cord, like Dr. Sue's saying. It's not just uppers only, hands only, burning dysesthesias. It's myelopathy, upper and lower extremity deficits, sensory deficits, motor deficits. It's acute and it's traumatic, but it's not so much like a fracture dislocation, right? So I think we want to try to get some better language around what does it really mean to have a central cord, in 2021. I think most people, when they describe central cord, are not talking about classic, pure central cord neurological symptom or syndrome rather. But that's a good question. And I think my thinking, and that's changed quite a bit. 10 years ago, 15 years ago, anybody with a spondylotic neck that was stable, right? The rule of thumb was to wait it out. And maybe a couple of weeks later, if they needed to go back to the OR, you take them back to the OR. Now, for me, it's almost like treat it like a cord injury, get them decompressed, unless there's some extenuating circumstance that prohibits you from doing it. Other questions? I think we're off to a good start. I think that was a really nice first lecture. There's a lot to cover. So I know we went well over time. We're going to try to do better in the future, but as long as the conversation's flowing, it's worthwhile. I will stop sharing this, hopefully. And I'll sign off, just say thanks to everybody for jumping on. Please, we want to get as many of the residents and fellows on the calls. So please share this around, make sure people are getting the invitations. The more people that sign on, the better in terms of the conversation. And as I showed you at the beginning, and as we can email out, we have a couple of really good lectures coming up. The next one's on thoracolumbar trauma that Dr. Divi will be giving. Hopefully he won't be scrubbed in while he's giving it. So we'll be able to see him and talk to him. But with that, I'll let you guys get going. Everybody have a good evening. And we'll see you in a week.
Thanks a lot,
Dr.
Dr.
Patel.
Patel.